Going on?
Good morning, Jeff. How you doing?
I'm good. What's new on your end of the world?
Ain't nothing new on my end, man. You know what? I'm glad to talk to you this morning. That's what's new on my end.
Cool. Where are you?
I'm in New York City.
Okay, got it.
I'm in New York. Oscar will be on in a minute. Let me tell them, matter of fact, that we're in.
Yeah. I came in early. I was just, I do this thing where I'm sure everybody in the world does it, but when you got a couple minutes and you're trying to get out emails, and then all of a sudden you're 3 minutes late. So
Yeah, I had to. I came on to set my scenery. And
yeah, I noticed. I was going to ask if you were at a dance club, but
nah, this is just one of the backdrops that I had located in. It seems just about. If you really look at where I live at now, I'm on the 34th floor, so at night it's just like that.
I bet.
Yeah,
Yeah, I bet. That's cool.
yeah, we right in the middle of Manhattan on Second Avenue and East 92nd Street.
Oh, that's good. Yeah, my dad's from the Bronx, so I'm familiar with New York enough. But as you know, the Bronx are not where you are. So
Yeah, oh, it's definitely a night and day kind of situation. I worked in the Bronx for a few years, so it's kind of tough.
yeah, that's all right. Tough lives make tough people, right?
Oh, no doubt about it. I
That's
mean,
right.
no doubt about it. So I'm trying to get this guy to come on because
You're good, man. I was early, so if you had something ending at 10, we're good. Tell me about yourself, man.
well, I've been in the substance abuse field for about 22 years, and just really starting off as sort of like a mentor. Well, I really started counseling through a Department of Labor apprenticeship program. So it gave me the opportunity to work with individuals that was incarcerated. So
Yeah.
I just really, yeah, and it was, different kind of individuals. And when I saw that it was not too much different from just ordinary conversations, because in my mind then it wasn't as clinical as it may be now. To me, it was just about engagement. So I just continued down that road from there. I mean, substance abuse and alcoholism, those things have been in my family since, I can remember. My father died at 40 years old. He was an intravenous drug user.
Hmm.
So he had used drugs with brothers and guys in the streets in these little shooting galleries. So he contracted AIDS. So that's where a lot of my prior experience come from. Hey, Oscar, how you doing?
Hey, how's it going?
Good, 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 good. We have Jeff online here. Jeff, Oscar, Jeff.
Nice to
Hey,
meet
Jeff.
you.
Yeah, good to meet you as well.
Yeah, so that's where a lot of my experiences come out of. I guess that I really just took that experience from within my household and ran in that same direction, and I've been there ever since. So
That's awesome.
we are where we are.
You don't know this about me, but I ran a substance use dependency center that was trying to do some significant groundbreaking stuff. Um, Worked with the VA, worked with the White House. I was on a task force at the White House for a while on opioids, and then worked with HHS on their opioid task force as well. So I am beyond familiar with that arena. It's good work. We need good people doing good work on that stuff.
It's tough work. When I read your profile, I saw that you had a lot of experience with agencies like the White House and the drug policy think tanks and all the rest of that. So I was like, wow, you are someone that we would like to get to know. Oscar, I know, because I don't want to monopolize your time with my stuff. Oscar, you the data guy, so the conversation is yours.
All right. So first, what kind of questions can I answer for you up front before we get this party started?
Well, I'm just trying to. I went on to one of the links that you guys sent me, and it took me to Remedy, So are you working with Remedy? Are you designing
Yes.
for them? What's the
Remedy? We have a partnership agreement with Remedy. They have a pretty massive database when it comes to COVID testing and then pharmaceutical pharma testing. So that's why we have a partnership agreement with them. We're not. It's not working for them. You know, it's just equal partnership.
Yeah, I got it. That makes
So
sense.
far, they're trying to use their Remedy front end as the inbound source and resulting source. They would connect to whatever lab, and they go that way. We would get the data from from the database to feed the visualization and analytics.
So are you working with David there?
Yeah,
Okay.
we the lab, Beech Tree Lab, has been working with them for about a little over a year and a half, and I do all the integrations at the lab. That's one of the things I cover. And so when when COVID was really going, we got in with them because we liked their front end and their state and federal reporting capability that makes life a lot easier in the COVID space.
Yep.
So actually, I have David on speed dial, but I actually work with Deepak a lot. Just it's Deepak's more of the go-to guy, and
Okay.
David when I need a 911.
Yeah, David's been I've known David through I'm on the Global Crisis Coordination Center board, and which is also part of the Global Health Center of Innovation. And so David and I started engaging as these lab tests were coming through, and we had some that we were trying to bring new tests in from a group in Singapore that increased sensitivity. It turned into kind of a little bit of a fiasco because they were like one test away from their FDA clearance, and they could never get that one to go. Like you had to be at 95%, and they were at like 94.2. And then they do 100 more tests, and one of those tests would be off, and so then they'd be at like 94.6. It was just like, but I know David from engagement there. I think they're in South Carolina, in Greenville, if I'm not mistaken. Yeah.
Yep, they're down in Greenville. We were actually using the Korean kits. That's how we for Osang. So that's how we were getting our specificity as high as we got it.
Makes sense. What about and so you guys now tell me what the business. I'm trying to understand that so that I can then give you context on some of the things I'm working on.
So Roots is wholly independent of the lab. None of the lab ownership has any ownership or play in the Roots model, because that way we could be, we're lab agnostic. We don't the database, we designed it in such a way that any lab testing data, no matter what kind, it doesn't matter whether it's toxicology or blood or DOT testing or FAA or cancer screening, all of it, the system is made to ingest that and then connect that with like census database, or for toxicology at a more local / state level, adding like a criminal database so that you could see. And we just had this use case in Utah, where we were meeting with their leaders, where they wanted to be able to see end to end, where they could see, Bob was arrested here. Well, Bob doesn't live here. Bob lives over here, because that helps drive. If you know where Bob lives and what Bob is being arrested for, if it's a drug crime, the crime problem is here. The drug problem actually goes back to here. And that's where they need to focus programs and things there. We did a really quick demo with them showing that in this one space in Utah, and I'll show it to you in a second, that there weren't people that were in the time frame they were looking at. There was one young man that met their criteria, and he was compliant. So in that time frame, they didn't have a drug problem; they had a crime problem. So using those types of things to be able to see a true end to end of not just, Bob was picked up here. Bob actually lives over here. He went to this court, was sentenced by this judge to this treatment program. And how effective is that treatment program?
Yeah. And so who is your end client? Who are you providing this information to?
Our goal client would be governmental, so local, county, state, federal, and we're, I know Remedy is actually pursuing foreign that we would provide the same capabilities for. Do we have the ability for a clinical level? Yes, we do. We have CFR 42 and HIPAA capability. This whole thing is a HIPAA and CFR 42 compliant database, and all of the functionality is covered. It's just that's less of a thing for us. More would be like I said, the governmental. But yes, we certainly can produce that data as long as we have the right credentialing and to ensure that everyone in that process is legit to access the correct info. That's the last thing I want, is somebody through most likely ignorance to incorrectly access someone's information, and then we have a hellstorm to pay for it.
Yeah, especially depending on the state. That gets out in Texas, you guys are sunk, having worked there before.
Yeah.
All right, so then and then within the government, is this more of a play to CDC? Is this a play to kind of local health agencies?
It's all of it, because the system is made to so what I'm going to show you is just simply we took what a couple people in Utah said they wanted to see and made visualize what they wanted to see. If I have the data, I can visualize anything.
Right.
That's the thing. It's all based on what the data is. We paid for Domo. Domo is Power BI is a very powerful product, but visually it's not always the best, and it takes pretty much a master's in Power BI to really make it start to look good. Domo is built to be a beautiful product that's easy on the eyes for the end user. So if the data is there, I can visualize it.
Okay.
And run predictive analytics against it.
Okay, makes sense. Let's see what you got. You want to show me? Because I'm a visual guy, so that always helps me.
I totally get it. Oh, hey, Thurman, you've disabled participant screen sharing. You either have to give me control or turn that on.
I will give you control. Just give me 1 second to.
No problem.
Kind of got a DJ look now that I think about it, Thurman.
Yeah, let me.
Just need some lights and little thumping music.
Like a headphone on your side, nod your head.
Yep.
Multiple participants
You guys were talking about where you came from. Before here, I ran an entertainment company up in Seattle. And
oh, really?
Yeah, the biggest entertainment company up there, and we did all of that. It was my break from software and IT. And so, yeah, when you talk about DJs, we had in the summer, we had 17 out at any given time.
That's amazing. 17
DJs and about 20 MCs, photo booth, lighting, sound, the whole kit and caboodle.
How about now, Oscar? You got it?
Let me see. Yep, here we go. All right, so I've switched over to screen. Are you able to see my screen at this time?
Yep, got it.
Yep.
Okay. So again, like I said, we're partnered with Remedy. That's why we put their name on it with ours. They're still working on their front end solution that incorporates this. But for now, there's no reason to bring up their page. Selectable by date range, really simple. Right now, there's only a 90-day data set in there. I'm pulling a new data set. I've just been waiting to get, the bigger the data set, the better it is. The map's interactive as one would expect it to be. In the use case, we picked this spot called Magna. You can choose what you want to see, and the map is reactive as well as the visualizations down here. Interesting point of it is everyone talks about like fentanyl, they talk about illicit substances. That's here, right here. That's how big that is.
And what's the source of the data?
This came from the Beech Tree Lab in Utah. And
No, I guess what I'm asking is when you see something substance divided by class, is this pharmaceutical data? Is this arrest record data?
oh no, this is testing or either pharmaceutical or illicit drug class.
This is this is the results from lab tests that have been okay. So this isn't, it doesn't blend in like if someone was arrested for pot, right? That wouldn't be in there. It would only be if they were tested.
Yeah, there's no this visualization. I'm not allowed to show the Utah criminal database.
Yeah, okay, got it. And then that makes sense. And then in the regions, is the region based on the lab testees zip code? Is that how it
Yes.
isolates down? Okay.
Yes, that's their home, where they listed their home address. Which, when they're tested, their home address is usually
tied to an insurance card.
Accurate, because they're being sent. They're coming from a court. Almost every single one of these came from a court case, so their address is pretty accurate.
Okay, got it.
So, male, female, other, some pretty standard stuff there. And then in that window, the big thing that they started to see is this stuff, antidepressants.
Yeah.
That blows the door. The misuse of antidepressants makes the fentanyl. Yes, fentanyl gets a lot of attention and it's a big thing, but the misuse of antidepressants is orders and orders of magnitude.
Yeah, I mean, yeah, it's hard to say what misuse is because you don't know what the direction is of the clinician, and that's I haven't usually seen a black market for antidepressants because you can go in and say I'm sad today, and a doctor will write you a script.
Oh, that's I would I hate to be a naysayer, but I would bet everything that I'm worth that you're wrong.
Really interesting.
Yes, because what the next data set, and I'll show it to you when I get it in. The next data set is the thing that you're missing is compliance, and it will be in this next set. So when it just had to get it in, and the compliance for some of these, for the mental health drugs can be as low as 7%. And so what's happening is they're prescribed X makes them sick to their stomach. They don't take it. They black market that and trade it for something that works for them. And it may not work because they may be bipolar and they're taking this thinking it's going to work, but really it makes their symptoms even worse. This is one of those things that Mike Isom, he's our clinical guy. He can explain that to a level far better than I can. But the reality is the misuse, actual intentional misuse of mental health medication dwarfs everything else in the mix. And it drives so many other things that when, like I said, give me about a week. And then because the data is there in the database, just I had to get it out of the database in a usable format. Once I can put that into here and show you the compliance, it's actually it's terrifying what the truth is in that.
It's very strange. All right, well, I'm looking forward to seeing that.
Yeah, and so, but that'll be just another card that I probably will actually put right here, number one card, and then move that one over, because the impact when you see the compliance rates for these different things is astonishing at just how poor it really is. The other scary thing is if we have clinician prescription information, prescription inbound, then I can show you they were prescribed X. Is X present in their system? Yes, no. If it's present, great. If it's not present, I'm going to show you it's not there. I'm also going to show you what is there. And usually you're going to find, if X isn't present, you're going to find something else that is present that shouldn't be, and it's not prescribed. So that one, like I said, give me about a week. Once that's there, it's because I can see it in the lab, but I can't mix those two worlds right now.
Okay.
Get it in here. And like I said, all of this is customizable. And so this is just what Utah wanted to see. So that's what we built. And then the by gender and dates that we're picking stuff up it's a very interesting thing. If you knew you had a rave, you could see between the genders who attended it, how old they were, and what date it happened.
Yeah, it's like, not surprisingly, people had a party on the 4th of July.
Right, exactly. And these are right there. That's what went hot. So it's an interesting thing. This is, again, it's a pretty simplistic because I can't show criminal. That's a very, I'm NDA'd on that one. But we just haven't had anybody else say, I want to see this. So, but if their data's there, I can visualize it and I can run predictive on it.
Okay.
What kind of questions you got for me?
What was the use case for this Utah group? What was it they were trying to drive to?
They wanted to see the last one, young men in that had drug issues, and they picked Magna because they were going to put a treatment facility and program out in Magna. And when we looked in that date range, there's not one. But when I put that with their criminal database, we went through and meticulously we went through them and we tracked those people back to these areas out here. That's where you need the programs, not Magna. Magna is just where the drugs come in and are bought. And
so people this is kind of like the marketing geolocation, right? Go where the clients are type scenario.
Yeah. And then we're looking at another one in Alaska that's a far more micro. Instead of state, they're wanting to do it by correctional facility because the truth, everyone knows that illicit substances are getting into the correctional facilities.
Yeah.
It would be to take their data in from picture a horseshoe, and it's broken into sections, and each of those sections do the testing and say, okay, well, section A we're seeing all of this there. Section C, we're seeing almost nothing. So then we can track down and find out where is it coming from? Those kind of things. It was more micro, but it's the same exact function.
So have you guys done anything with SAMHSA at all?
No, we have not done anything with them, but if they gave me a need and I had a data source, I can produce it.
Yeah, it's that's the thing, right? So there's a lot of I'm just giving you kind of like my take. There are a lot of companies out there that hit up the government and say, if you give me your data, let me show you what I can do with it. Right. So some of the value that you have is saying, I already have some data. I can, with more data, I can power the model even stronger.
Yeah.
So the first thing you have to do is create the differentiation. The second thing is create the use case, right? So whether that's, and I'm probably telling you things you've thought about 1,000 times, but since this is the first time I'm seeing it, right? I'm just, my personality is to kind of talk through it. What would someone do with this data, right? Is the next logical line of question, right? Having information and acting on information are two separate things. And so you kind of have to, I'll give you an example, right? When in one of my previous companies, I was working with the White House of Office of Science and Technology, and we were going through the creation of science called nanotechnology, and then we advanced the ball. In order to advance the ball beyond a certain point, we had to get language put into a congressional bill. So I worked through that group, but in order to get the White House support, I had to go to the Office of Management and Budget and show the downstream impact of paying $10 more for something one time over a lifetime and what good that would do, right? And so then there was a congressional budget score. In that instance, right, the need was clinical value. The hurdle, right, was budgetary. And then the use case was pick the patients. And so we would target osteopenia, osteoporotic, et cetera. In your case, right, I see the need. The need is identify areas, areas with either vulnerable populations, individuals that are testing right at blank blank, right? So what is the use case? Because the government may argue the use case should be delivered to a private company that gets paid to put these services in place for these individuals. And you would then come back and say, well, not necessarily, right? This is why this is valuable to the government. And these are the action steps you can take off of this.
Right. So this is a place that Mike is far better. He has been engaged in this conversation far more, because we're working with the Utah state legislature, the Utah, Alabama, and Alaska for that exact purpose that you just described. To say, because it's not just that use case. There's the use case of, if you're a person that's in the system and you go and are tested, you can be tested 4 times in 4 days, and Medicaid just paid for all of that, or Medicare just paid for all of that, when in reality, the first test could have been valid for all of them. So there's a massive cost savings effect. There are many other use cases than just targeting one. That by putting the data together, there's many ways to see what's going on.
And do you have, and I know you can't show it here, but do you have access to data at the patient level to understand disease states, right?
Yes.
Like, so if someone comes in on a cannabinoid, again, I don't know why that one's always doesn't come off my tongue very well.
I know, it gets us all.
I would be like in the middle of an interview when I was a C-suite guy running these things, and I'd be like, I'm just going to avoid that term altogether and say marijuana because it's easier. But if someone is right, so depending on the state, depending on the clinician, depending on the right, if my mom had breast cancer and was fearful of opioid addiction because that prevalence runs in the family, she may alter to that treatment source. Well, now, is that a problem, right? Or is that a solution? Is that a long-term thing or a short-term thing? All of those pieces are important. Look at that, Thurman. Who is this?
That's my little one. She all over the place. I mean, I'm like,
Hey,
oh my God.
What's your name?
Celestine.
Wonderful. I got a 3.5-year-old that barges in from time to time, so I get it.
Mine are a lot older than that. My youngest is 13, so
good for you. I didn't start until I was in my 40s, so the financials are secure, but the knees are weak. Should have probably done it the other way around.
Yeah.
So I just want to kind of ask the question again, because you're targeting government, right? Do you have, and if this is a conversation for Mike, then we can loop back on it.
Do we have patient level data? Yes.
Okay, and then what are the use cases? Because eventually you got to figure out how to monetize this, right?
For the clinical side, it's more than they want to be able to see is Bob's treatment regimen. Bob's treatment regimen should be ABC. One, is Bob actually taking ABC? And if he's not, what's actually happening? What is the reality? And so I'll be honest, I don't see a lot of value for small clinics. Now, for a larger health system, anything that's got they're getting Medicaid or Medicare funding, they're a large multi-facility system from around any state, but a multi-facility large testing operation. That's the larger their operation, the more value they have. Because most places, if they're a small pain clinic, they already get their lab values. And so the smaller they are, the more intimate the care. But once you get up into the larger systems, that's where being able to use this and use the clinical side of this where you can drill all the way down to Bob and see all of Bob's specific stuff, that's where it becomes more useful. And we up in New York, we talked to a couple nonprofits that they had some very specific one-off use cases around, but it's the same thing. It's just they wanted to set up for us to intake additional information from like a counseling, structured counseling and add that to toxicology and say, if I'm seeing these things in their counseling, what's happening in their toxicology?
Right. So there's some predictability, right?
Yeah. And again, that becomes more about predictive analytics. And we met with a guy he's marketing a whole very specific structured counseling thing that, again, if we could match that with toxicology, with like say criminal, if you're seeing this in counseling, well, we know historically when you see this, you also see this, thus you should be looking for these things.
Right.
So
I mean, I'm trying to think through the use cases for you beyond that, right?
Yep.
I think a service like this allows for expansive geographic coverage, especially in the areas that we're talking about, right? Telehealth has made a significant move primarily in the mental health space and substance use disorder space, because those individuals could not afford the disruption and therefore they pushed on. It's a wonderful thing to see technology kind of breaking through. In that world, right, you're looking for like, let's say you worked with IHS, the Indian Health Systems, which obviously they're in every state, right? My wife's doing curriculum development for Indians in Virginia right now, Native Americans in Virginia, but they call themselves Indians, so not being insensitive, following their terms. So, what I'm wondering is in individuals that have a genetic predisposition for addiction, right, which is clearly there.
Yes.
Is there an opportunity to identify when something starts to pop up and assess whether or not the education levels or the clinical treatment levels, et cetera, are meeting standards, substandard, or are showing a difference, right? You're going to have to find a way to make this in some way valuable monetarily to someone who's probably receiving funds from somewhere else, right? So a treatment center, something like that. Or you need to work with payers, right? Like a United Healthcare, Blue Cross, something like that, to say, here's a very unique subset of individuals. What we have the ability to do is overlap, and if we have the right information, I can tell you which centers appear to be successful in reduction, right? Both short-term and long-term, because anyone that's really worked in the treatment world knows there's kind of two standards, right? One is get them in, flush everything out, and get them back out there. But if you push them back out into a socioeconomic arena where their entertainment is and access to narcotics is right there, odds of remission are very strong, right?
Yeah.
I mean, so a relapse. I'm sorry, I said remission, but relapse. You guys knew where I was going with that.
Yep.
So, so if you can get to a point where you can then start saying, what is the most effective treatment? What are the most effective therapies, right? We had a pretty strong belief, we being my HHS committee had a fairly strong belief that it was a combination of tapering mixed with, at times you would mix that with substitute, right? But most of the time was tapering with physical therapy and behavioral therapy, right? You got to get to the root cause of the mental, physical in order to address the chemical, and you have to address the chemical along the way.
Yep.
So that was what the science we were looking at was suggesting. I've read a lot of papers that look at other paths, right? But whether you're looking at a 12-step program, whether you're looking at a complete system flush, understanding what works is very valuable. And it may be that it works different depending on the type of drug, right? Methamphetamine is certainly going to grasp you a lot harder than cocaine, as an example, right?
Well, you have that, and then you also have a little bit of background. When you say a family predisposition, there's a reason I don't touch any of it, and I never have, because my family did. and my family is a use case in disaster of it. So even that predisposition, if any of those markers, so I hear exactly and feel that there's a whole set of things there. It all comes down to from the data guy, it all comes down to the data. If I have it, I can mix it, mash it, smash it, and visualize it. It's just the getting it.
Right. That's right. I understand that, but you're going to have to prove in advance before someone just says, "Oh, sure."
Exactly. No
thousands
one's
of
just going
pages
to
of
hand you it. There, but only a hand. There, it's a rare person who's going to go, "Oh, cool. Here's my data. Do something with it."
That's right. I mean, the legal risk associated with that is tremendous. You might also look at the DoD. So there's a pretty significant problem that's happening right now, and we're aware of it, right? Everyone's somewhat aware of it. Where you have troops, and then they reach a certain age, knees and ankles start to hurt from jumping out of planes and running across the ground, et
That's
cetera,
the.
right?
I
And
was
so
15 years in SOCOM, so yeah.
right. And so we start with anti-inflammatories, and then we work our way up to Tylenol X, and then we progress, and next thing you know, it's Ultraset, and next thing you know, and so by the time someone is deemed disabled and goes to the VA, right, or when they come back from war, and there's been some type of extreme measure along with the mental aspects associated with battle, you are on the incoming percentage of individuals that have some degree of addiction and reliance going into the VA, right?
Yeah.
Is I don't remember what the number is, and unfortunately, Admiral Jawad is no longer at HHS. Otherwise, I'd call the former secretary because he used to rattle those numbers right off his head. And Admiral Levine is there now, but I work mostly with her sub teams. But anyway, it was like an 8 to 10 fold, right, delta.
I've
So
been to the VA system. I've been on the receiving end of exactly what you're talking about. 15 years in SOCOM, knees, ankles, back, shattered skull, PTSD, and the first thing the VA wants to do is give me opioids. That's the thing they tried to do.
Well, I mean, it was actually written effectively into their law that it is unlawful to force a veteran who served to deal with their pain, right? And so that was the go-to. And a lot of studies and a lot of effort was done through Purdue Pharma and others to make sure that was the narrative. So there's not a lot that can be done retroactively, right?
But I see exactly
what it is. But I think if you could identify, I'm just trying to figure out like what are if I was on, I try to look at everything as if I was on a committee or a board for that company, and I was having a conversation with someone at a very high level in the target space. In your case, government. In other cases, payers, United, et cetera. How would I take the information that you have and try to make it so that it creates clinical and monetary value, right? And some of what you're saying is, if you tell me what you want, I can build it, right? Which is totally fair. But if you're on the back end of that, giving real life examples to say, let me give you examples of what we're doing, like you've been saying, right? But really draw those out, make those conclusions very evident. I think that'll be helpful to kind of button that down in advance. And maybe that's what Matt does, right? I'm Mike. Was it Mike or Matt?
And that's it is. Usually he's the clinical guy and he's the pretty boy face of it. I am not the pretty boy face of it. And so this is actually this is his baby. I came into it about a year and a half ago and walked into his office and he had something drawn on his board. I looked at him and went, "Hey, what's that?" And he goes, "I want to do that." And I went, "Okay, I can build that." And fast forward, and we did.
Yeah. And one of the things that adds value, because I hear what you're saying, Jeff, is redundancy testing. When me and Mike looked at it, we thought that this particular technology could help save Medicaid and Medicare 40%. And just the elimination of redundancy testing in general, because you can have one person, he may be a criminal justice person, who goes to a MAT program, who get tested by a diversion program, who goes to the doctor and get these tests. So there are one person doing 3 or 4 tests a week. But if you have a database or a streamlined process, because Beechtree, they are able to test the person and detect what's in that person's system over the course of 7 days. So really one test would eliminate the other 3 tests, and Medicaid and Medicare pays the same money to the same laboratory for all of those tests. So the profit testing would be eliminated.
Yeah, that makes sense. See, that's a great use case. And if you can monetize that and say, spend on laboratory test averages blank, there are X number of individuals that are tested a week, right? And you can ballpark things. People accept ballpark numbers. I think that's really helpful.
And one of the other, go ahead.
Go ahead. No, go ahead.
One of the other things that we looked at is the co-occurring disorders. Most laboratories, when they test for things, they may test for 5 to 12 different things. They will tell a client, well, listen, these things that you have access to, these particular tests, all you got to do is click off. But if you want anything more than that, there is an additional pay for those additional things to be looked at. Beechtree, they all automatically look at 116, analytes, and they test for 30 prescription drug medications, and they have a validity panel that makes the distinction between synthetic urine and human urine. So there is this huge value in being able to detect what's happening with a person at the earliest possible stage. So if you can look at someone within a period of 7 days and they are, given urine samples, you don't have to test this person 12 times a month. You can test this person 4 times a month. And I will be able to go to a judge and stand on it legally and say to a court, Your Honor, this person is compliant, has maintained total abstinence for all mood-altering substances. And I have the accuracy and the validity to say that. Most laboratories, they don't have that.
Yeah.
So it's really about picking up, having the sensitivity to pick up substances that are prescribed, substances that aren't prescribed, and really communicate them back out, because there's a history of results of a particular person that could basically be looked at a glance and say, hey, this person has been compliant until this date. Then all of a sudden, we got some craziness going on. So there's definitely value. Besides, we can target the conversation, around validity testing, around just a higher standard of patient care.
Yeah, I think what you're alluding to is, right, you're going to add costs to run this, but you are going to recoup that through efficiency and effectiveness, right?
Yeah, but like I said, Medicaid pays the same dollar, so we're just saying, hey, we add more value, even though we're getting paid the same dollar. One of our greatest interests is the data, data, because that's going to give us the ability to do some analytics, predict things, and be able to really look at the lay of the land in a way that no other laboratory can.
Yeah, data is currency for sure. Right. You look at the Fortune top 25, right? And how many of those companies have a foundational aspect of their business from data? Almost all of them, right? Even the insurance companies, right? I mean, United Healthcare went from a top 20 company to a top 5 company when they added Optum, which was all about data. And then with data, they picked which physicians to bring on, and now they're the largest employer of physicians, right? I mean, it's all a play on information, and to that point, informatics and data are the value that people are looking at. With healthcare data, of course, you can't sell it, right? So you have to sell the trends, not the individuals.
Yep.
That makes sense. So how can I help you guys?
That's a question that I to be straight out, I don't get involved in. So again, I'm an operations guy. I turn people's beautiful ideas into beautiful reality. My guess it from the outside world, my guess is that one, your feedback has been a lot of it is along the same lines we've been discussing, but you brought some nuance to it that I don't think we've had that discussion yet. So that'll be helpful. And once I have the other data piece in, I think it might give you a different view that even if you could go back and have a different conversation with someone saying, I've seen data that shows that what you're saying is patently false.
Mhm.
And here's why. That helps people make better decisions when they have better data. The other part is more of the introduction of, hey, these guys are doing something different, and I've seen it.
Yeah, well, yeah, I mean, the differentiation piece, one of the things that we got to drive to in order to get success is differentiating between causation and correlation, right?
Mhm.
I mean,
Yeah.
that's one of the trickiest things with data. Is there's still a black sheet where some information is limited, and trying to get to a level of confidence that this is what's causing something rather than I don't know if you guys are familiar with the ice cream drowning study, right? Where as ice cream consumption in Wisconsin increases, drownings also increase,
Right.
So you could draw the assumption that it causes drowning. It turns out they're just in the summer people eat ice cream and they swim in the lake, right? And that's the only time where it's warm enough to do so.
Right. So I totally get that. I came out of Nike and Alaska Airlines where we built an intake capability where it took in everything, even social media. So if you suddenly have a volume decrease in a store in North Dakota, it looks at the why. Why is that? Causation versus correlation. And so I definitely hear that. And you're right. There's some things that it's always, unless you have 100% data, it's going to be a true best guess. But the truth is, reality with the right data, you can get to a 90% plus.
And what I would add is, because Oscar, you're going to put more data into what it is that you're doing, so that hopefully, Jeff, we can circle back with you and show you that information. And the only reason Mike isn't on the call today, he had some laboratory people from some health department people from New York coming down to Utah that he had to meet with. But we definitely want to have him on the call with you. I'm gonna share this recording with him. So we would definitely like to circle back with you and have another discussion with you. Maybe it'll give you some chance between now and then to really think about what it is that we're doing and where you could, give us some more feedback.
Yeah, I mean, I guess part of it is I'm just trying to continue to understand. Is this an SAS service that you're walking into a major health system with, a community hospital with? Is it targeted towards substance abuse? Are you expanding it into other arenas? Right. Those are all the things, because then you can say, oh, you would pair nicely with blank, right?
Right.
In medicine, we make decisions off of objective and subjective information. You guys have a wealth of objective information, right? That has value, and trying to understand that at a clinical level, at a patient level. I haven't seen that, so I can't infer, right, from this conversation how much value is there on that. But from like a 10,000-foot value looking down, it seems fairly obvious that you're talking about effectiveness and efficiencies, trends. Is education working in school systems in this area, for example, right? If Nancy Reagan had this back in that day, her Just Say No campaign would have looked different, because they would have targeted education in the areas where the problems are greater, right? Or you may have a more targeted approach, right? For example, we see in rural settings, methamphetamines are much higher, and in urban areas, we see more marijuana. I'm just
throwing things out. Yeah.
Right. That's right. So what are the trends, and then how do you combat those trends at a national level based on needs, right? And if you start with the assumption that societally we spend blank, and of that, this is the percent that comes from the federal government, and this is the percent that comes from employers, and this is the percent that comes from payers, et cetera, then you could start building out your business plan on who to approach, because you're going to have a multifaceted business plan, because you don't know which group is going to be the one that picks up on this, right?
Right.
Absolutely correct. Because when I thought about it, I was thinking, hey, listen, I mean, there's these pool of people or pool of providers that could really benefit from the testing aspect of it. You know, most clients we had when we was in New York last week, and we had a point of care cup where one of those regular urinalysis cups, and we took some Monster and poured it into the cup, and it tested positive for amphetamines. So there was something that triggered the amphetamine tab on that point of care cup. So what we was really trying to demonstrate to folks is that, you know, when we have folks coming into treatment and we are using the point of care cups to determine what's in the person's system, you know, we can really be doing the client a disservice, because they could have a false positive. So really, laboratory testing and the accuracy of those testing, you need to have a lab that you can depend on, and not just a lab that's going to say, well, pass or fail. I need a laboratory to tell me whether or not my urine is authentic or human urine. I needed to tell me whether or not they're prescribed or non-prescribed chemicals in this person's body. And I would also like to have a history of the laboratory test, so that way when I start to look at the clinical value or what type of interventions to formulate for the person, I have some information, some objective data to really look at that's going to help me formulate that. So when I first met Mike, I was coming to the table from that perspective. And then I started to realize that, you know, with talking to Mike, how Medicaid and Medicare would, you know, really benefit from this type of information. So it's like levels to what can take place with this type of data.
You can also, if you can incorporate additional data, right?
Yep.
You can also try to start driving down to root cause to get more predictability, right? So, I mean, it is no secret that the United States turns to alcohol first, marijuana second, illicit drugs third, right? And depending on your state, marijuana falls in the last category or the first category.
Right.
But they look at that as a pathway to disassociate from stressful life, right?
Yep.
And so if you had, for example,
economic downturn happens, the more there will be.
that's right. And so, you know, is there a way to incorporate? So, Oscar, my company has the ability to send a text to someone, and from that text, I can take your heart rate, your breathing rate, your SpO2, and your blood pressure using the camera on your phone.
Mm-hmm. Yep.
Right, at a clinical level, FDA clinical level.
Right.
So, is there the ability to incorporate into analytics? If I took a test, if someone was in a substance use dependency, you know, kind of an intensive outpatient, right? To stare at your phone for 20 seconds 3 times a day, and all of a sudden have objective measurements that say, man, at 5 o'clock when this person comes home from work, their blood pressure is 10 points higher than when they start the day.
Yep.
And then suddenly by 7 p.m., their blood pressure is 10 points lower than when they started the day, right? What was it that allowed that individual to go from hypertensive to almost hypotensive? And it doesn't always necessarily have to be substances, right? It could be meditation, it could be exercise, it could be a lot of different things. It could be that's the first time that day that they see their little kid, and the endorphins from the engagement with a child are known to calm people down, right? There's a lot of things, but
right.
understanding that then creates, you know, health system model for trends. And if we understand, so now I'm trying to get into remember, in substance use dependency, we're treating the mental aspects, the chemical aspects, and the physiological aspects. You have to treat all 3 of them across the board, right?
Right.
And so if I understand that this period of time, if I was a counselor, right, and I knew that everything seems to go from here to here in these 2-hour periods every single week. What is it that's happening there, right? And if it's exercise or if it's diet, right? If it's just I didn't, I'm a blue collar worker and I didn't get lunch today, right? And my body gets all ramped up, and then all of a sudden I eat and I calm down. Whatever it is, understanding that
It forms
if it
the
turns
question.
out to be a substance that is causing that, then right, from a medical standpoint, that pulling that person off of that substance is going to continue that clinical path where there's a physiological response that they're trying to address.
Yep.
And now if you don't address that, you
There-
are
something else.
doomed, right? They're always going to go back to, they're always going to relapse, because at some point taking someone off medication without fixing the problem is not going to be a long-term solution.
They will
So,
either return to the same thing or they'll find something new to fill it.
That's right. So I'm just trying to make sure that as we're having this conversation, expand the way that, and I'm not saying you're not expanding the way you're thinking. I'm expanding the way that we're thinking on this conversation, which has only been 50 minutes. You guys may have whiteboarded this already, and it may already be out there, and you're like, this guy's making, no shit comments across the board. But in the event that I'm not, I'm just trying to think out loud of how we would address this at a macro level, because I think the platform that you offer is macro until you can get down to digestible segments and improve the clinical aspects by having those types of predictability.
Yeah.
Pieces.
So
that's where
right
that's where those you were saying earlier, the ability to have a counselor add their comments in order to help things drive predictability. This is where it kind of all comes together, right? If you because that's subjective, and the only way to get that information is through an individual that has direct engagement.
Right. And so, well, they're talking about, so one of our specific, we're looking to partner with her in a small demo cases. It's instead of it being a professional conversation, it provides an app to the person who's in counseling so that they're not feel in a judgmental thing. It's just, how am I doing today? It's 10 questions. 9 of them are, Saffir scale 1 through 5, and 1 is a free form text that we AI scrape. And so that's just another data inbound that then I can connect to, and say, as long as I have the unique identifiers to identify Bob, and it's the right Bob, connect all that together. And so to your point of, yeah, I can, if you have the data of your phone that scans these 5 things, as long as I can connect it to the right Bob, I can perform a whole picture of the right Bob.
Yeah, that's there's a lot of ifs there, right? So breaking them down and saying, I have this, and this
Yes.
already here. So the only if left is this, and I can contract directly with said provider. I can launch, these additional questions from within our system rather than adding an external, right? How do you beef up what you have in order to, and that may be, you push those through the lab testing company, right? So then all the same feedback comes back in. There's a lot of opportunity. It's the devil's in the details, and the organization and the structure is what's going to get you there, my personal opinion. And you may already be there, right? I'm just
you're hitting a lot of that. Like I said, you're hitting a lot of things, and I don't take it as the duh. I take it as that it's a validation of what we're going down the right way. Because it completely, in your position and outside influence of, in that position, you're asking questions that we did, and you're bringing some nuance that we hadn't touched yet. So there's a lot of value, at least for me, coming out of this conversation.
Well, I was on C-SPAN right behind Admiral Jawai in the last opioid crisis coordination meeting, and the members of Congress would say, can you create a list of like 50 questions? And then their staffer would run into me and say, which ones have been asked and which ones hadn't. So what you see on C-SPAN is total crap, right? The full room of all the members of Congress doing this and leaning in, right? That happens. And then about 10 minutes later, the cameras go off and 70% stand up and vacate. A staffer stays in the room to take notes. And then they go off and do meetings. And then they come back when it's their turn to ask the questions. And so, so they try to keep individuals with big ideas on the ready in those meetings, so that they can send someone in and say, what good questions do you have left? I want to look intelligent in front of my constituents.
So one of the things I would like to do is I would like to consult with Mike and find out when he would have some available time, send you that information and see, what your schedule would look like. And hopefully we can have another conversation with you with all of the people that need to be in the room.
Yeah, I mean, let's explore it further. I think, understanding the need, right? Just like you guys are saying, if I have the data, I can get you the answer. If I understand the need, right, and the need comes from what is the end product that we're trying to put out, what is the value of that product, who are the individuals that purchase that product, right? The commercialization aspect of delivering a product is significant because you're developing towards something, right? And I get the sense,
because we thought it was a good idea,
right? Well, it is a good idea,
but that's
right?
not the whole reason we did it.
But I mean, but this is like, the reality is, you could swing a dead cat around your head and 8 times out of 10 hit someone that says, if you give me data, I can do something with it, right? So and we face that, right? Every new company faces that. How do you differentiate against the competition? And so the ability to like really dig in on that and really focus on what their needs are, where their pain points are. I mean, that's marketing 101, but really driving down at the clinical value, since you're talking about macro efficiencies and effectiveness, right? All the way down to patient level efficiencies and effectiveness. Who wins from that, right?
Everyone.
Patients, right? The patients and the payers, right? I mean, you can make an argument on society, but how do you monetize that?
Right. Well,
Right.
you can monetize that in your criminal justice system. That's because that is one of the prime use cases that we're seeing in Utah is the desire to reduce cost of paying out for Medicare, but also what is outcomes. What are the, and if I can see who's providing better outcomes, I can find out why the other people aren't, what other programs aren't, and I can help people have better outcomes, which then saves the system as well, because they can monetize people being in for drug crimes.
But Oscar, what you're really doing is informing individuals who can take action that lead to the criminal piece, right? The information itself, producing the information does not directly reduce downstream criminal activity, right?
True.
Producing the information allows police to know where to go to try to shut things down. It allows teachers to understand from an educational standpoint, what do we need to be talking about in school, right? Should we be shifting some of our sex education to drug education, right? As an example, should we take a day off the playground and show, go back to the old style? And you guys can tell I was a 70s kid raised in the 80s and 90s. It was like, here's your brain, and it was an egg. And then scrambled egg was, here's your brain on drugs, right? I mean, I remember that stuff. It worked. And, and then we would go into jump rope for your heart. And, I mean,
remember
it depends on what the need is, right? And it depends on who you're counting on to make the change. What you're saying is that we can empower them by giving them better data. So there's a link there that has to connect, and you're smart to be connecting them to the providers on the substance use dependency level, right? Bringing it all together and saying, once we have that connection, the next step is now to do assessments and understand if someone did physical therapy twice a week and they were on this drug and they did one counseling session a week, what was the effectiveness, right? Not the effectiveness based on the patient saying, I feel great, but the effectiveness based on a noticeable reduction of drugs in that individual system, right? And then if you can continue, that's it. That's the, the aha moment is, number one, can I get someone into a place where they are substance free or substance reduced in a non-harm setting, right? And then number two, once they leave our program, how long do they maintain, right? Do they go on to is it 5% that never use something again and 95% that come back? Of the 95%, is 80% back within 3 months? Because then your true effectiveness is 20%, 15% that lasted a year, right? And the 5% that never used again. And that's how the ability to show those types of trends is how you will get just crazy amounts of traction in the space.
Got it. I love it.
Yeah.
Thank you for the feedback. That helps
Yeah,
me.
man.
It helps me guide where I focus getting data from.
Yeah, that and $4 will get you a Starbucks coffee, right?
No, that and $10 will get me a Starbucks cup.
Probably.
Yeah.
One of my colleagues, she gets coffee almost every day, and she came in voicing her unhappiness with a $9.80 cup of coffee, and I looked at her and said, "Well, you know how to fix that." So, but yeah, no, it helped. It does help because we're pursuing other data sources that give us other things. Like I'm trying to think of a way where I could show you the clinical side, because the clinical side exists. I just can't, I can't just.
I can do an NDA. I mean, I'm not worried about that. And in a BAA scenario, right? I can do it as an individual that sits on committees on substance use dependency, right? So
It's just how to, and then once we have that, I can show you all the way down to that level. It's just no one has needed it yet. You're the first one that really has that. So I have the NDA, BA, that kind of stuff. I can send that to you.
Yeah.
And then when we set up the next call, I'll have the rest of that next piece of the data set, which will then show those other pieces of what are you taking versus what are you prescribed? Are you trying to subvert the system? That urine, are you trying to use fake urine? Are you trying to get around it? All those pieces, and down to the clinical side, which then will give you a better the next level of picture.
Makes total sense. Okay, guys, that works for me. So so the follow up, you're going to send me an NDA so that we can get a little more detail.
Yep, and your email is just, I can scrape it off of this invitation, right?
Yeah, I think did you use Mindset Medical?
Yeah.
Jeff on Mindset, yeah, that's fine.
Okay.
I'll make sure you have everything else.
Okay, and then I'll just it'll come in and it'll be signed, because I hate dealing with paper.
Yeah, I'll just let me. The only thing I have to do is just make sure that there's not. This is a list of companies that I advise, right? So I just have to make sure that I don't. The only thing I ever worry about is something that says if there's an idea that comes up in conversation, right, then we own the rights to that, because sometimes I'm trying to transfer knowledge of what someone else can do to kind of combine those two.
So then we have this piece of a conversation. This process is patent pending. What we're doing is patent pending, and that covers pretty much everything we've discussed today.
Excellent. That's good. I mean, I'm happy to hear that. I'm just saying that, like, from a 20,000 foot view, because I have purview to a lot of stuff. I just have to make sure that I disclose that I am not empowered to give someone else's intellectual property to you guys, because if there's an area where I've been permitted to discuss it, right? That's the only.
Yeah, that's so that I'll send it to you in a Word doc then, so you can look at it and bleed on it if you need to. So that way because I don't want to infringe on anybody else's, just like I don't want mine infringed on.
Yeah,
so
don't worry. As you can tell, if I'm having this conversation with you on the front end, I have this conversation with everyone, right? I'm not
exactly.
I have my own stuff that's mine, but for the most part, I want to see success in healthcare innovation, and the way you do that is by communicating. And if it ever gets to a point where I feel like I can't represent that, then I would just give one of you guys to represent it, right?
Right.
If there was a conversation that needed to happen at a state or federal level, as an example.
Yep, got it. And we may never hit that point, or may hit a point where there's some sort of partnership level that's available as well. That's whatever happens.
Yep, perfect. All right, gentlemen.
Jeff, thank you very much, man. We appreciate you.
Thank you very much.
Okay, it's fun having these discussions. It's been a couple of years since I really did the deep dive into this kind of stuff, and I miss it. It feels good to help people.
Yeah. Thank you, man. We appreciate it. We'll be in contact.
All right, bye.
Bye.
All right, Oscar.